Now we will briefly tackle acute rhinosinusitis, albeit in a little bit less depth than pharyngitis. And here, diagnostically, this presents even more of a challenge than strep did. The gold standard on figuring out if it's viral or bacterial is a sinus puncture and aspiration. Well, how many of those are we going to be doing in the office or recommending that any of our patients go to a specialist to get done? Uh, the answer is not many. So imaging also isn't terribly useful, especially in the case of acute sinusitis. Perhaps we'd refer someone with chronic sinus issues to have a head and sinus CT. But again, that's not our case here. Bacterial is more likely if symptoms persist for more than 10 days, if double sickening or double worsening occurs, where someone is sick for maybe a week or so, then they start to feel better for a few days, and then they really start to tank. And bacterial etiology is more likely with high fever or facial pain that lasts more than 3 days. So distilling that all down into the American College of Physicians CDC guidelines, um, antibiotics are not recommended unless you have symptoms for more than 10 days, or fever greater than 102 and purulent drainage, or severe facial pain for more than 3 days, um, or symptoms of sort of double worsening, particularly with initial viral illness that lasted, a little under a week, and then you feel better for a few days, and then again, just feel horribly worse. Once again, we will attack this in a Goldilocks manner here. Um, Contestant or patient A is a 45-year-old woman who complains of some really gunky green stuff coming out of her nose. She says, it looks so gross. Oh, it must be bacterial. It can't be a cold. She's had symptoms for 4 days. She's afebrile in the office. She has some mild sinus tenderness. Our middle patient is a 49-year-old man with purulent nasal discharge. Had it for 9 days. Says it hurts really bad. Every time I reach down to the bottom shelf in my kitchen, that's where all my cleaning supplies are. It just, my head feels like it's about to explode. That even his teeth hurt for the past couple days. A mildly elevated temperature in the office. And our final contestant, 57-year-old woman, notes having what it seemed like a cold 2 weeks ago. Then she felt like she was getting better for a week, and now she's got purulent green nasal discharge, facial pain for 4 days, just horrible, horrible pain, so severe it's made sleep difficult. Sinuses are extraordinarily tender to palpation and has a temperature of 102. She sounds like someone who we might be giving antibiotics to. Uh, on a immediate basis. So let's see. Yes, it was indeed the middle person again who presents this kind of equivocal presentation, and we may pursue a delayed antibiotic strategy. So what does that mean for acute rhinosinusitis? Well, in this case, guidelines suggest um, augmentin or amoxicillin clavulanate uh, twice daily for 5 days. Now, um, it's common to see 10-day courses prescribed for sinus infections. That is too long, according to these new guidelines. Really 5, possibly 7, but really 5 to 7 days is the new standard. We're going to advise that the patient return to pick up their script. There's no improvement in 7 days, or if their symptoms deteriorate rapidly, if they spike a high fever, develop rigors, facial pain increases, I'm going to want them to call me, and we may put in a prescription right then and there. But again, 7 days is the recommended um, delay from the United Kingdom authorities. And I'm going to reinforce with them that very few sinus infections are bacterial. It's likely viral. Doesn't make it any better. It's not going to be comfortable, but it's likely viral. And they can last 2 to 3 weeks with or without antibiotics. Then I'll make some recommendations for symptom control: Tylenol for fever, NSAIDs for pain, some nasal saline irrigation for the congestion, possibly mucolytic medications. And if they're really really miserable, possibly some intranasal steroids, just to decrease some of that swelling. So when I was looking at this slide, I actually thought, oh, I kind of like the prescribe, advise, reinforce, recommend mantra there. I don't know if it can be parlayed into any sort of useful acronym, PAR, I suppose. But um, really, that's going to be our approach with these patients. We're going to write the prescription, but then we're going to tell them not to pick it up immediately, and we're going to encourage them, tell them that they're probably going to get better without the antibiotics, but then also treat their symptoms and also create the safety net if they get worse. So that's sort of the beauty of using a delayed prescription strategy. And I just wanted to take a few moments to review here after those case studies or micro case studies that delayed prescribing is not meant to replace clinical judgment. Doesn't mean we offer it to all patients. It's not, oh, anybody who comes in the door, we say, well, here's an antibiotic, take it maybe or not. No, it's much more specific, targeted, and research and guideline based. So it's a tool to move forward in the face of diagnostic uncertainty and vulnerable populations, such as the fella in one of the case studies who is on Xeljanz, who is going to be immune suppressed, or folks with cancers, other chronic illnesses, deserve special consideration because honestly, they might not be the appropriate candidates for a delayed prescription. And again, the research seems to indicate, and remember, this was not statistically significantly determined. There was no test of statistical significance. This was just an association, but it seems to be that returning to pick up a prescription leads to slightly lower antibiotic use rates. Is this good? Is this bad? I don't know. I mean, one benefit of having this extra barrier is that, yeah, people who really probably don't need antibiotics aren't going to go out of their way to drop by the doctor's office and pick them up. But what if the patient has poor access to transportation, or is in some other way unreliable, or is traveling? Maybe that's not so good. So maybe we want to modulate how we delay our prescription based on the individual characteristics of the patient. For most people, have them come back, but if we really are worried about follow up, maybe we do send them with that prescription in their hand and just request that they not redeem it unless they feel like they're getting worse, or don't get better in the specified amount of time. And finally, clear instructions and education along with the delayed prescription seem to be associated with lower antibiotic use. And here I'm speaking about the randomized controlled trials that ended up having lower antibiotic use than the cohort study, which just tracked people who had been assigned a delayed antibiotic, um, and yeah, tracked whether or not they ended up using it. So just make sure you're spending time with your patients to uh, explain to them why you're doing this, what your expectations are, um, and yeah, just give them a little bit more information about the process.